Test, test, test. Testing 1, 2, 3. Testing 3, 2, 1.
What does it mean to be always ready? It means having a level 1 trauma center that
God. You are indeed the giver of all good gifts, and we come together this day to seek your wisdom, guidance, courage, and strength. As we experience unprecedented times, inspire us to solve the challenges we may face. Be with us in our deliberations and help us to be wise in the decisions we make for JPS and the good of all those who have placed their trust and confidence in our leadership. Give us insight to lead with integrity, that our decisions may reflect what is right and good. Keep us from short-sightedness, and even if we have different opinions, give us unity of spirit. Finally, we ask that you would grant us through humility to always seek your will in all that we do. Our glory be to you, loving God, now and forever. Amen.
Amen. All righty. I pledge
allegiance to the flag of the United States of America and to the republic for which it stands, one nation, under God, indivisible, with liberty and justice for all.
Do we have any citizens, Suzanne?
No, we do not.
No citizens. The next item I have is the approval of the minutes from 12 August 2021.
Move approval of the minutes.
Second by Charlie. Discussion. All in favor, please say aye.
Aye.
Those opposed, say no.
What's that side of the room door?
My board chair report starts in the same way it's been going for a year and a half, which is thank you, thank you, thank you. If you would, though, how about if we just took about 3 or 4 to 5 seconds and bowed our heads in remembrance of all those that died or was affected by 9/11, if we may. Just a few seconds. All righty. My board chair report, Robert will cover most of the stuff, but I did sit down and reflect on some stuff. So I wrote down the things that I always think about, and especially for all the people that are working hard to take care of all these COVID patients, and not just the COVID patients, but all the patients that we see all the time. And the first, and some of these things people do all the time, and I just want to articulate it in my own way. And number one is be humane and kind in one's life and in the patient-centered world. An overemphasis on science may tip the scales away from caring and being compassionate. The rapid changes in the healthcare delivery system are challenging to all, but give good guidance to all. May you not dwell on the morbid or mistakes, and do not be anxious about what the future may bring. Use all of your resources to focus on today. Always anticipate the need for perspective and the relationship between patient and oneself. To quote, our main business is not to see what is dim in the distance, but to focus on today. I urge you to learn to control the events of today, but recognize that the past may haunt, but try not to have any concern for oneself. May you not let the mistakes of yesterday paralyze you from doing what needs to be done today. Moderation is difficult, but the caring for patients requires extreme mental and physical work, which should be done without alcohol or drugs, i.e. abstinence. And may you demonstrate physical self-control to have clear judgment on a wide variety of knowledge and thought. Work hard, but remember, your heart may lie with taking care of patients, but always leave some room for other pursuits, especially. And now I'd like to sort of loosely quote Sir William Osler and Marcus Aurelius. You must, this is for the people that are having to change gowns and go in patients' rooms and all that kind of stuff all the time. And you must be like a promontory of the sea. The waves will beat you continuously, but yet like a rock, you will take the pounding, so you make smart decisions of today as you care for those seeking compassion and care. And that's my chairman's report for the day, sir.
All right. Good.
Mr. Chair, it is appreciated, and it does sort of dovetail to the comments I would make. It's frustrating. If you're outside of these walls, and even outside of being a board member, and you don't realize what goes on here, it's easy not to think of what is going on here. It's easy not to realize that we have an ICU that is at capacity. It's easy to not realize that if you had the ability, which we do, to extend the ICU, we don't have the staff to do it. And it's really difficult. I'm asked all the time, do you have room over there at JPS? We have plenty of room. It's staffing. And if you talk to people that you know at Baylor, and if you talk to people at THR and HCA, they'll tell you the same things. I meet with them on a weekly basis. We are not any different than anybody else. The other thing, if you take politics aside and you take personal opinions aside, or you take what you might read from somebody on a social networking page, the one thing that is evident to us is, and Janet Miles and Jocelyn Z and others, Steve Davis, see this on a daily basis. Over 90% of those in our ICU that are struggling right now are unvaccinated people. It's not a political statement. It's not a statement to sway anybody on anything. It's the fact of what's coming in JPS that is in the most difficult of positions. So in that world, and I apologize for any oration that I may give you, but this weekend was a difficult one for me because I was in a few community settings where I saw people who were lashing out in anger because of their fear. And it was difficult. I went into an establishment and there was a lady and she was yelling at the people behind the window with racial slurs. And I could see my wife boiling over. So I decided that I would calm my wife down because I knew that Tricia was going to get into some form of a wrestling match and I didn't want that to happen. So I calmed Tricia down and I said, I don't think you should intervene. And the lady kept saying racial slurs that were out of line and not fitting for a community standard. And so I calmed Tricia down well, and then I blew up. And I told the lady she should leave the establishment and that there was no place for that. She didn't agree with me, and she had words to me, but I would rather her voice her racial slurs to me than to the sweet person behind the registry desk who was scared to death. And there's no place for that type of anger. I went to Viola Pitts a couple of weeks ago, and we had one nurse trying to accommodate people on the first day of providing boosters to everybody, and the people that were getting their boosters were mad because we were delayed in giving them their booster shots. We were really trying to make sure that we had documented things properly. We were trying to make sure on the first day that our computers were where they needed to be. And we have a lot of people that are reading a lot of things on social media who may have had the Pfizer shot who now want a Moderna booster. And according to where CDC is at the present time, we're not doing that. If that changes, we'll be the first to be right there next to CDC to change. But CDC has not recommended that we mix vaccines. And the group of people were really frustrated and they were yelling at our nurse. And our nurse is just there to help. And it's really difficult that fear has translated to anger. And anger has translated into unfortunate political decisions, which should not be the order of the day. So the only thing that we can do, or I can do, as being a part of this organization, and maybe you can do as board members, is deal with our own. Deal with your own life. And I know that you all would probably have done the same thing I would have done, and I did at that store by asking that lady to please leave and stop making racial slurs. There's no place for it at all. It's just not purposeful. It's horrible. And I think what we need to do is for the 7,200 people that we have some relationship with that work here, is help them and be there for them the best we can. There are people that truly wear angel wings in this place. There are people that have 5 children that are getting phone calls 3 times a day to take their kids out of school because they were subjected to a COVID child, and they're running here and trying to take kids out of school and putting their kids in quarantine. You know, even talking to board members, even talking to Trent Petty, and he Trent has 3 boys, and I pity him because they're eating drywall at his house and tearing things down, and that's boys. And he's constantly running around trying to figure out which kid is in school and which kid is not in school. Every time I talk to Trent, he's back and forth to the school trying to figure out who to pull out and who to keep in.
Fix that drywall.
Yeah, fix the drywall. So the fact that you have nurses that are at bedside and you have technicians and you have doctors that are at bedside is pretty amazing. I got an email from one of our doctors, and he cited a resident. And what we had going on was a really challenging family situation. And it was a really difficult situation. And the family member was here in our ED, but was not maybe getting the support from their family that they needed. And our resident stepped in to help in a variety of ways, including financial, to help that individual. And it was pretty powerful. And you hear stories like that all the time here at JPS. They're not one-offs. They're pretty amazing. So I just wanted to echo the words of the chair and say that I think at this time, we're all in this place for a reason. I get to sit next to Steve Simmons for a purpose. I get to meet with Dorothy and Chuck for a reason. And I'm not going to miss out on that. And because of that, I think we have to step up and help society when it needs help, because it's suffering. And people are having unfortunate answers to their challenges, and it's going the wrong way. So we need to do everything we can to help our community in Fort Worth and Tarrant County and the state of Texas and the nation be the best we can be. And I think there's probably no more better time than to invoke those 3 rules of realizing what ownership means and smiling and seeking joy during your day and never being a jerk. And I think that will help. I wanted to give an update on the foundation. We have, as I've mentioned to y'all before, and Amanda, I know that you have appropriately asked for updates from the foundation at the board meetings. There's really not an update per se to have staff come to the board today, because we don't have the leadership that we had obviously with Ms. Labby's retirement. We don't have the leadership there, so there's not an update from the staff, but there is an update with what we're doing on the search. We have enlisted the support of the Hearts Group. The Hearts Group have helped us on our last 4 searches. They've done a good job. There's no reason to not bring them on board, because they've been pretty effective at bringing folks like Brian Becker here and Mark Hallman and others, and I think those are really strong members of our team. They were strong candidates, and now they're strong members of our team. So the Hearts team is now going through both a local emphasis and a national search for the best people. And they're doing it at the same time that they're doing a few other searches for us, and I think they're doing a really good job. So Amanda, they will, and I'm not singling this out to you, but I mentioned your name because you have unfortunately made eye contact with me, and what that means is you're going to be on the search review committee, and that means you will briefly eat a lunch. So, yeah. Nobody's looking at anybody, as y'all. Nobody's looking at me. Nobody's looking at other board members. Like, don't look at him. He's going to assign us to something. But you will play, and I think you have a gift for understanding some of the things that go on in a foundation. You've done work in the past, and I think just as Trent helps us with things from his past as a city manager or Pastor Emerson helps us with the issues, not only with the city, but running a church. Everybody adds some element. Your element of helping us with the foundation, I think, will be critically helpful to us. And I think you'll have a good eye for looking at those candidates. So you'll be a part of that. When we get, what happens at this stage is the Hearts group will go through about 60, 70 of the most viable applications. They usually limit that to the top 10 to 15, and then they will meet with us and go over those, and then we will select those top 5 or top 10 to be interviewed. And we are asking that those interviews be in person, not virtual. So wanted to give you all an update on that. The last thing I wanted to do is leave you all with a bit of a feeling of some of the things that go on here and the kind of people that we are. We are submitting this next 30 seconds to the Dallas-Fort Worth Hospital Council to let them know what JPS does. Lewis in our communications team is a pretty incredible person. He and Brian put videos together for us. Brian, as you know, does a lot of videos for us. He does our photography for us. Every picture you see up in the building is a Brian photograph. He and Lewis really did this video himself. Lewis actually hurt himself, hurt his leg, so he hasn't been able to actually walk. So he did this video all from his computer system at home. And for those of you who have the level of computer intelligence that I have, I find that pretty phenomenal, because my intelligence level is, if the button is on the right, I push it in and the computer comes on, and that's the extent of my knowledge. So he can take those computer skills and work from his desktop at home and put a commercial like this together. So Jeff, if you would run that video, I'd appreciate it.
Robert, one of the reasons you have problems with your computer, the on-off button's on the left.
Thanks, I appreciate it. I don't know what I'm turning on the right, but that's what I'm doing.
What does it mean to be always ready? It means having a level 1 trauma center that ranks as one of the best in the nation. It means being named the #1 hospital in America because of how we serve our community. Always ready means, in the face of a pandemic, we didn't back off. We stepped up to keep our community safe. It means getting patients off the streets and giving them a brand new outlook on life. It means not being afraid to take on behavioral health issues and ensure that our patients get the best care around. It means teaching our caregivers today so they'll be prepared to serve you in the future. Always ready means having the best nurses, and we have all the awards and accreditations to prove it. For nearly 150 years, JPS has been the cornerstone of Tarrant County, and for many years to come, JPS will always be ready.
He did a wonderful job with that. And what I want you all to know is, and you all know this as board members, is when you have challenges when your facility is reaching capacity, when you have challenges because your community clinics are trying to give booster shots and first shots and second shots and deal with everybody who's coming into the community clinic at the same time, and you're dealing with coding issues, and you're dealing with all types of issues, there's never one issue at JPS. And we are always ready, because when somebody in the community or somebody on social media or any place wants to focus on an element of what we do, we will address that along with the other 69 elements we're doing. So there's never a time where you really have the ability to not do anything except cross-train. And I talked to one of our doctors on the way up here, and she mentioned the 3 areas that she was working in this week, and none of those 3 areas were the areas that we hired her to work in, because she's going where she's needed to be. And if you talk to anybody on the staff here, there's a good chance that they've worked in our environmental services, our laundry services, or our EVS services in some form or fashion, because when you find out you have less people that you need to have a full scale working, then others step in. So it's pretty amazing, and I want to thank you as board members because you all have had that burden too, and the community is a tough place right now. That's why I think we need to remember our 3 rules and be the best we can possibly be in the community in which we live in, because it's a good community. It's just a little wobbly right now. They're a little off balance, and we need to do everything we can to help keep the balance. So thank you.
The video set us up because I looked up and then I looked over, and Roger had turned around in his chair. I said, oh, he at the movie theater. So I just knew they was bringing popcorn in, but the movie went off.
It's true, and we'll get as much distribution to that. The amazing thing about that is everything's in-house. The voiceover for that is the administrative assistant for our communications department, Lewis, putting that together, and then the pictures and videos that Brian grabbed. All that's done in-house, and they're pretty good. That would compete against anybody that would charge us significantly more dollars who do that only every day. So thank you all very much for tolerating my comments today, but it's an important place doing important things. Mr. Chair, that's all I have.
Anybody have comments, questions for Robert or me? There's one thing I forgot in my report, and that is, for those of you who remember Scott Fisher, he was chairman of the board here for a while. He had on YouTube the musings of a Texas preacher man, where he would do 12 to 15-minute Bible studies 4 days a week. And he stopped doing that when he moved to Memphis to be near with his family, and his wife got a better job. Much better than Scott's job. But he has restarted his musings of a Texas preacher man, 12 to 15-minute Bible study things on Scripture. I'll probably get in trouble for mentioning this in a public forum, you know.
I'm not making eye contact with you.
Yeah, I know.
I did want to give you all a quick update. I'm remiss in one thing, Mr. Chair, and that is I did want to give you all an update. You all and we discussed at length mandatory vaccines, and we listened to what the medical staff had told us, and you all asked us as staff to look at the policy at trying to figure that issue out. That policy would then come back to you all, and you would debate that policy to see if it was appropriate and if that's what we wanted to do. Daphne has done an incredible amount of labor between the last board meeting and this board meeting. The governor has come out with an executive order, and in that executive order, it refers to the fact that the governor certainly is not supportive of mandatory vaccines, and I'm not quoting the executive order, but has the ability to withhold funds from us. And I'll remind you that Medicaid and Medicare dollars do pass through the state before they are allocated to us. So that is something that is substantial. So Daphne's work was really helpful to us because she communicated with most of the major public hospitals in Texas, as well as the not-for-profit and private hospitals in the Dallas-Fort Worth region. And we're all collectively trying to figure out what we do and how we answer that edict. There is not a position that I want JPS to be in where we are, and Roger and I talked about this, there's no reason to take the governor's order and defy it. It is a matter of a position that the governor has taken. We are a government entity in a lot of respects. 60% of our overall budget does come from tax dollars, directly or indirectly, and we need to be cautious about how we handle things. So we and the other public hospitals, along with the not-for-profit and private hospitals, have tapped the brakes on mandatory vaccines until we get further legal review of it, until we figure out exactly where we are. You all will not be seeing a policy brought to you by the staff. So I didn't want you all to say, well, it's next meeting and you all said you would be bringing us something. I think at this time it would be inappropriate to bring you something, so we're not going to be doing that. But we will keep you all up to date as to what Daphne is looking at from the legal side. But the great thing about bringing Daphne on our team is her connection with the legal staffs of so many others, particularly the public hospitals and certainly with Parkland. It's a huge benefit. She's got them on speed dial and they've got her on speed dial. So just wanted to give you an update. I didn't want unfinished business to be sitting out there, but that's the reason you don't have a policy today, is we're looking at the legal ramifications of it. Daphne, is that appropriate?
Yeah.
Or do you want to correct me? Because you can.
Go ahead.
You can.
I don't have any.
You can be like the board chair and correct me all the time. It's all right.
You want me to just add something just for the sake of adding it? No, that's, you've summarized it appropriately. The resolution you passed was giving direction to move forward once we received full FDA approval of the vaccine. There was subsequently an executive order that made clear that the inability for government entities to mandate applied to fully approved vaccines as well. So we are revisiting that and we'll bring more information back to the board.
One of the saddest things
Can I
about
just ask one question on that? As you look at that and the governor says he can hold funds, would that affect our IGT payments too? Would we look at that too?
Dorothy, I can't.
Oh, I'm
Yeah,
sorry.
I'm sorry.
I was just saying that as we look at that with him withholding funds, could we look at how that would impact our IGT payments that we sent up to get those dollars back? Because we do play a big part in that.
Right.
Okay.
No, good comment. One of the saddest things for me is that all this vaccine business has become more political than have anything to do with healthcare. But, all right, department update. I see Miss Laura back there.
As you all know, what we do every month is we flip clinical to non-clinical, and you get a report from staff members talking about those areas. The patient experience and what we do in interacting with our patients, and then what we report from the standpoint of what information goes into the aspects of leapfrog and also CMS reporting data, and all falls under Laura Burnside. It's one portion of what Laura Burnside does. We thought it would be helpful, because this is the month for a non-clinical report to you all, to give you all an idea about, she gives you dashboards at every committee meeting, pretty much, from quality, even to governance. You'll oftentimes get some of Laura's work in there. But we wanted to go a little bit more in depth about where we were and where our numbers are. And if you look at our numbers in its totality, if you look at our numbers and how we compare to safety net hospitals, and if you look at where we are if you weren't in a pandemic, because it makes a big difference in what you can hit and what you can't hit. So Laura's going to go through that, and Reverend Emerson, you would be proud of us. We are now pretty much putting an org chart into every presentation. Now, I will say that it was 7 years, but we are putting org charts into everything. We may be slow, but we get it right at some point.
I think it's over 12 years when they're out.
My math is a little off, just like I don't know where my computer button is. So 12 years, we've turned 12 years around. So Laura Burnside, let's go into the detail, and thank y'all. And if y'all obviously have questions, go through that, because this goes a little bit deeper than what we'd normally go when you get a presentation on some of our numbers.
Laura, if you would, in your presentation, number one is on the second page. I don't know what BH stands for.
On this.
You'll get to it. But
Okay.
More than likely, it's behavioral
Oh, okay.
health.
Behavioral health is what it would
Behavioral
stand for, yeah. On the graph of the numbers, I'm assuming you're
And the
talking
second
about.
thing, explain it as if the only people listening were people out in the community, so that they can get a good grasp of what we understand is a great job.
Sure. Thank you. I appreciate being here today, and thank you, Robert, for that. It's Always my pleasure to speak on the work that the team does. I have the enormous privilege and honor to work beside some of, I think, the most special individuals that I've ever worked with. They bring a tremendous amount of heart to the table and a tremendous skill set that we frankly have had to expand and push this last year. It's been a really different year, as we've talked about. I heard Chaplain Sylvia talk about courage and wisdom and guidance, and I think if I had to sum it up, those are probably 3 words that we use every single day on how do we move forward to be the best that we can be as an organization and guide our team members to be the best that they can be and support them in a way that allows them to serve our patients and our community as we should and as they deserve. Dr. Weber, you talked about science and care and compassion, and I think this is exactly the combination of those traits. There is some science to it with the survey data and the research that goes in it, and then there's a ton of care and compassion that we provide on all levels, whether that be to our team members, to our clinicians, or to the patients that we serve. So our goal through all of this is to really focus and anticipate what is coming and be able to provide that support the best that we can be. Our patient experience division is set up differently than what I have seen on a national level. We believe very strongly that our patient experience team is really here to help create a great space for our clinicians, for our employees, and then ultimately the patients that we serve, because we know that those are very connected and there's no way to disconnect those things. So what you see in this organizational chart, and Reverend Emerson, I hope this is helpful, we have some traditional departments like patient experience, for instance, who works on the tactics and strategies and tools to be able to help us know what our patients need, want, and desire in order to meet those needs. And then we also have departments within the division that support our employees. And so the chaplains, for instance, through the Spiritual Care and Ethics Department, report up through this division. The Employee Assistance Program, or you'll see that on your chart as the EAP, is a therapy service and counseling service that we offer to employees and their family members. And we'll talk about that a little bit more in depth in just a moment. And then additionally, we, of course, handle any of the concerns or compliments that our patients and their family members provide, whether that be through a phone conversation, a face-to-face encounter, or an email or a letter that would come in. Any questions on sort of high-level view of the department as a whole? Okay. The next slide is just a compilation of the information that I shared last week at the Quality Board meeting. And on this slide, Dr. Weber, it is behavioral health. So we measure and survey what our patients say and the voice of our patient and our family members throughout the network. And whether that be on the inpatient side, the outpatient clinic side, the emergency services side, or our behavioral health side, we listen to that voice of the customer and we respond to it. And so as you can see on this slide, we are achieving our goals that we had set at the beginning of the year in all of these areas with the exception of 2. And the 2 that are not achieving goal, as you can imagine, have had tremendous disruption this year. So particularly on the inpatient side, and then with our operating services and the OR, with all of the changes that we had to make this year in order to accommodate the additional COVID patients that we had, you can see that those disruptions have really impacted the achievement of those goals this year. This is really different. Yes,
before you go.
Sure.
Before you go further, on the outpatient surgery, was that mostly because the surgery was delayed?
I can go back and look at exactly what it was. It's a variety of things, though. We measure all kinds of elements through that. We use the OAS CAP survey, which comes from CMS, and you can see even the score here is really high. So in order to achieve really top measures in the country, you're really within the 90% top box range. So even when you see that we did not achieve goal in the outpatient surgery, the performance level overall is quite high when it comes to the percentage of patients who selected a top box answer.
Okay. I just know that we use COVID affected everything, so I was just wondering if that would be the main reason, since for outpatient, if you did the surgery, usually your outcomes and measurements would stay up. So that was one of the reasons I was thinking it maybe failed out.
No, it's a really, really smart way to think about it. The top answer that I recall off the top of my head was around communication, which is typical. And so I think as there are delays, people are, of course, more frustrated, and a lot of times that can trickle down. So these results are a little bit different than what you see in a lot of years. You're very accustomed to seeing us achieve target or stretch, and again, I think it's just a demonstration of the impact of this year. But we continue to dig into all of this information in order to really understand it, because the data points tell us something, but they don't necessarily tell us the whole story. And so through comments from our patients, our discharge phone call team, who they've made 57,000 phone calls so far this year to patients, collecting that real-time data, being able to really make any adjustments that we can on the front end, so that as we continue the work that we do with our patients, we're doing it in a way that's really meaningful and helpful to them for their outcomes.
Let me ask you a question,
Sure.
if I may.
Yeah, absolutely.
I didn't have any idea what this was all about, and I picked up this piece of paper and looked at it. The thing that it looked like to me would be, for example, on the outpatient clinics, that only 62.6% we did hit the top box. But what that implies is we have about 40% where we're not doing well at all, and that's not what this reflects.
So the percentage that you're seeing, the 69.9%.
I want you to say it so that everybody else.
Yeah. So the 69.9% fiscal year to date, 21 fiscal year to date response means that almost 70%, so 69.9% of our patients selected a top box answer.
Right.
Shortly behind that is a large percentage of our patients that selected the next answer choice. And so our challenge here at JPS is going from what we consider good to great. It's not that it is a poor experience. We see very, very few surveys come back that show us that there's a poor experience. We actually see more that say it was a good experience, but there was something that we could have done to enhance it and make it a little bit better. And that's what these numbers reflect.
Right. See, for me, the numbers are outstanding, because in the face of all the COVID stuff, this is still the patients that we're taking care of on a daily basis, that we come back with this kind of data. Yeah. It's great.
And to Robert's point as well, thank you, Dr. Weber, on the inpatient side, our results are reflective of the number of domains that are in the 75th percentile or above. That is comparing ourselves to the top of the country against every hospital in the nation. And when you look at this, we're achieving 2 of those domains in the top of the country. When you compare us with the safety net hospitals nationally, we achieve 5. So when you really pull it down and look at like organizations, our results improve even in that respect. But this data is against every single hospital in the country.
Laura, can you also talk about the Spanish speaking survey, the conversation we had?
Yes, absolutely. So
Can you repeat that?
I was just asking about the Spanish language surveys and how that affects this particular survey and what those numbers were.
Okay.
Yes. So at the quality board meeting, Amanda asked a question that we had a chance to chat about last evening, and I wanted to be sure that I was providing information on this. We have distributed surveys to about 30% of our patients who, and by the way, we survey 100% of our inpatient population. So about 30% of those went to people who selected any language other than English. So all of our non-English speaking patients. We've received about 8% rather of those surveys back from that group. And in all areas, our results are much, much higher than they are with our English-speaking population. You can dig into some of the questions and really get a feel for where we have opportunities, but when it comes to the communication aspect or the discharge instructions or what do I need to do when I go home, our non-English speaking patients understand that better than, or certainly their perception is that they understand it better than those who speak English. And so we're going to talk about language services here in just a minute and our qualified bilingual assistance program, which has helped us be able to achieve those type of results as well. My pleasure. You also asked about the mastery program. We are actually on, I've mentioned this a couple times here at the board meeting. We are on our 6th cohort of our patient experience mastery program. It's an internal program that we designed and we facilitate. You have been a graduate of that. We've actually graduated 166 people through that program, and we are getting ready. We've done one pilot for residents in our OBGYN area, and we're starting our 2nd residency mastery program with sports medicine in the coming weeks, a couple weeks from now. So, other questions on this data? I would be remiss, once again, if we did not talk about the work that's been done through our Care for the Caregiver team. Our employee assistance program has conducted over 1,200 individual sessions this year. These are individual counseling or therapy sessions where our employees or their families have reached out for assistance. That number's up this year. Additionally, what's different is that 54% of these visits have to do with mental health related issues. These are related to anxiety, depression, and grief. Traditionally, the number one reason that people have reached out to the EAP for help is for their relationship challenges. We are not seeing that this year. What we're seeing is more job challenges. In fact, that hit the top 3 for the first time ever. And so through all of this information and through the Care for the Caregiver program as a whole, we are able to impact about 2,500 sessions a week. These are individual emotional support encounters that occur here at JPS on average every single week. Last year at this time, we were between 1,200 and 1,500. So in the last year, you can see that our team members are continuing to reach out and increase numbers for help, emotional support help. So about 3 or 4 years ago, we developed a Care for the Caregiver team. It consists of 4 directors here in the network. 2 of them are within the Patient Experience Division. One is our Executive Director of our chaplains, or Leanne Franklin, who you all know very well. The other is a director of our EAP. Her name is Anya Palacios. She is amazing and joined us recently from American Airlines. And then also Shannon Sims from our behavioral health side as an executive director is part of that group, and also Dr. Glenda Mutinda, who is part of our academic affairs and our director of interprofessional well-being. Those 4 have created programs and enhanced programs that we have had for the last several years in place, but tailored them to meet the needs of a team of people working through a pandemic and tailored them to meet the needs of a virtual world. And so each week, any of our care team can log in and participate in a variety of sessions, whether that has to do with Schwartz rounds or what they call healing conversations or leadership enrichment sessions, mindful minutes. We have a prayer line that they can call into, in addition to a variety of other mechanisms from debriefings and all kinds of things from moments where we've unfortunately lost some of our own.
If you are not in the hallways here on a daily basis, one could easily write some of this off and say, I think that's kind of fluff. Do you really need that? What you find is the caregivers that are under the levels of stress that they are on a normal basis has been amplified by COVID. And we celebrated, or we recognized, we didn't celebrate, we recognized 18 months since the first diagnosis of COVID, and we had a moment of silence on their green space. 18 months of dealing with this, and the challenge that we face with this particular crisis and why those numbers have escalated so much is because last year, COVID would come, it'd be here for 3 or 4 weeks, and then it would start to subside. It would go down, and it would go back up. It went in a wave-like situation. Right now, we're in COVID in a steady flow, and we're at 128 to 129 patients every day. And we're not seeing any light at the end of that tunnel. And it's challenging, and it's frustrating, and it's even compounded more because we had a belief that COVID may have been something that we could put behind us. 7 months ago, we were talking a lot about post-COVID. And now we're talking about the new variant of COVID, and that's hard on your employees. And that's hard particularly on the epicenter of where COVID patients are coming and where you're dealing with them. So when you have programs like this where people can reach out for psychiatric help, or behavioral health, or just somebody to talk to, this has nothing to do with fluff or do we really need those programs. They're critical by the numbers and indication of how many people utilize that. There are health networks that don't have this, and I think they're doing themselves an injustice by not having it. It's critically important.
Yeah, I would agree. Thank you. So additionally, we found a need for additional visibility, particularly from the executive team. We heard on numerous occasions that they wanted to see us, they wanted to be able to provide feedback, and so we enhanced the way that we did that, and we increased our visibility. We actually will touch 350 different areas this year. They're on schedule, and 1,100 conversations will occur. So it's quite a spread that we're doing as an executive team. Several months ago, you approved a software for us to be able to track this, and so we began using that about 90 days ago. And in the last 90 days, we have been able to resolve 55 items that we heard from our areas in which we rounded. And those are a variety of resolves, but there are some small, some bigger. And so we just want our employees and our teams to know we are listening and that we are here and walking this journey with them. Yes?
When you look, I'm just looking at this number, the 2,500 and the 1,200.
Yes.
What percentage of that, or is there a percentage of those who voluntarily come seeking help or assistance, and what percentage are those that we volunteer our services?
For the EAP, the majority of the 1,200 sessions that they've had this year have been voluntary. There are some where we find our employees are struggling, and we do work with our Human Resources Department to provide EAP as a resource for them, but those are very few, actually. Most of them are voluntary.
I would say, Reverend, that about 90, and you correct me if I'm wrong, Laura, about 95%
at least
of all those cases, if not more, are people volunteering to come in. We don't self-identify the employees. They're coming into our services.
Okay.
2,500, that's 100% voluntary.
Okay. The reason I ask that is because just being in a leadership position in municipal government, you always had that employee who was a top-notch employee, and then all of a sudden you start seeing a downturn in that employee. And the next thing you know, that employee is referred to HR and terminated.
Right.
Maybe that was a problem on the other side of that, and I was just wondering if we take any steps to kind of call in, do counseling, because it may not be just because I don't care about my job and job performance, but it could be an EAP problem.
Correct. Yes, and our EAP and HR work hand in hand. Whenever those situations occur, we do often, during performance counseling, they would get an EAP referral, But again, the number that you see there, it is mostly voluntary.
Good.
On the language services front, I actually did a couple of months ago a larger, more in-depth presentation on our language services team, but I did want to provide an update on our qualified bilingual assistance program. As the number of patients who come through our doors who are non-English speaking increases, we find a need to make sure that our services are sufficient for that need. And so to date, we have just under 150 certified bilingual assistants. 64% of those are nurses, and then we have 16 physicians that have participated in this program, and that's new this year. So that allows them to actually serve a patient in that language without having to call an interpreter. And they're medically tested so that we ensure they not only know how to speak conversationally, but they actually understand the medical dialogue or the medical language that goes with that, that particular language there. And most of those are Spanish, followed by Nepali. But our qualified bilingual assistance program has interpreted 1.2 million minutes this year. That's just those 149 people. There have been several other million minutes that have been distributed out to our interpreters and our vendors as well.
Are those positions for doctors and nurses, are they incentivized, or
They are now. It's very small, but for our qualified bilingual assistance program, we do have a small compensation that goes along with it now.
Good, thank you.
Yes. This is really, I think, an exciting program. It is unique to JPS. I have not found one other hospital that has done anything like this. And so over the course of the last 5.5 years since we started this program, I've been asked to speak on this nationally multiple times and to describe and talk about this ambassador program that we've created here. We initially had a problem of cascading communication to our frontline team members. And so we sat down and talked about ways that we could potentially combat that and get around that barrier. And we found that kind of deploying frontline team members to be that message taker was really helpful to get to their peers. And so to date, we have just under 500 JPS ambassadors. And these are people who are participating in monthly town halls. They are given activities or communications that they are then asked to bring back to their teams to help us with getting messages out to the organization as a whole. And so these 500 participate, like I said, in monthly town halls, in focus groups. They are think tanks for us. They have a tremendous pulse on the organization. And so a lot of times when Robert would like to get a message out to the network as a whole, he will send it to the ambassadors, get their feedback, and then we will adjust as needed or accordingly in order to make sure that the message would be understood by all that are working here at JPS. They're really, honestly, they are that pulse. And we go to them a lot for feedback, for information, and just to be able to help with moving even things as simple as our rules of the road. We have a rules of the road committee, and they send out on a weekly basis something that has to do with owning it, seeking joy, or not being a jerk, and what those behaviors would look like. They partner with us on large events. So when we had our hospital week, our thank you week, they distributed over 10,000 thank you cards. You saw a picture in the video that just played of one of our ambassadors standing in a room with a lot of food. They collected about 20,000 items of food last year that we did, or this past year, that we've distributed to community organizations in order to continue to assist our community. And so, oh yeah, this is a recognition opportunity, actually. These are highly engaged, high-performing employees that we elevate and ask them to participate with us in additional activities in order to move the organization forward.
Wonderful idea, it had to be yours, not.
So Robert has this wonderful way of I think I made eye contact, and
I think he is texting you right now.
I don't have my phone. It's a tremendously unique program, highly successful. We just actually oriented about 50 of them a week or so ago into the program. We have them make a pledge, we pin them with an I Own It pin, and then we ask them to be the example of our rules of the road, and not only demonstrate it, but help their team members demonstrate it as well.
Are they recommended to you, or?
They are. Yes, they are actually recommended by their leadership, and many of them actually have been promoted into leadership roles over the course of years. And, we've run turnover numbers for them. Their turnover rates are lower. They're just high-performing, really engaged individuals. And that's all I have for today.
Just a small amount, huh?
I know, I wish I
have
could talk about
comments?
all of it, but any questions that you have, I'm happy to answer.
Don't see any.
Okay.
Thank you.
Thank you so much.
Tell the team good work.
Thank you.
Good work indeed.
Mr. Chair,
Yes, sir.
I'd like to make a comment. Communication is one of the most important things in any organization. Laura's obviously and the boss here have done a good job at setting up that kind of an environment. But it is an environment. One of the things I learned at Lockheed Martin, we were doing a one-day shutdown of the plant to get rid of all unnecessary equipment and whatnot. And I was in charge of the factory, and it was from 7 o'clock in the morning till 7 o'clock in the morning. It's 3 o'clock in the morning, and I'm sitting out by the wing structure, and I'm dead. And one of the manufacturers came up to me and sat down and started visiting, and he said, "By the way, who are you?" And I said, "Well, I'm the VP of Product Support." He looked at me and he said, "You're the first person that's ever come down here dressed to listen." So the environment of communication is not just that your door is open. Mm-hmm. It's creating that environment, whatever it might be, that makes it feel comfortable for the employee to talk to us.
Mm-hmm. Point well taken. Yep. Thank you again, Laura. The next I have is item 8, Roman numeral 8, which is report from the medical staff staff committee.
Thank you,
That would
Mr.
be
Chairman.
Janet.
I appreciate the opportunity to stand in for Dr. Hurd, who is away doing some fun continuing medical education. In brief, our functions of the organized medical staff over the last month have been continued focus on the safety and quality of patient care. And to that end, we are providing oversight to the really strong work being done by the Patient Safety Quality Governance Committee and the PSI 90 scorecard. We also provide oversight for a number of other medical staff committees, including the Medical Record Committee, the Utilization Review Committee, the Ethics Committee, and Pharmacy and Therapeutics. So these are all committees that are really doing very, very good, strong work under the oversight of the MEC. We also approved a number of policies and procedures, as we seem to do every month, because we do look at a large majority of policies that come before this body first go through MEC for us to take a look at. And I'm really excited to tell you, based on your approval of the bylaws in June, we have 2 new departments at JPS under the medical staff. That is Women's and Children's Department, so that represents a combination of putting pediatrics and women's together into a Women's and Children's Department, because obviously those services are hand in glove. And then we also have a new Department of Hospital Medicine. And those departments have completed their elections for their new officers, and Dr. Sangha is the chair of Women's and Children's. and the vice chair is Stephanie Carson Henderson. You may recall Carson Henderson served as the interim while we were recruiting Dr. Sangha. Hospital medicine is Dr. Saba Assad, and I think you all are familiar with Dr. Assad. She's been before the board several times. She is the chair of the new hospital medicine department, and Dr. Jason Brewington, formerly of family practice, is now moved over and is with hospital medicine. So we're very excited to welcome those officers to the Medical Executive Committee. We will be holding our annual meeting very soon, and there is a slate of candidates that was approved at MEC that will be moving forward from the nominating committee for our annual elections for medical staff officers. Just a reminder, our medical staff officers have been expanded. We will have a president-elect, a secretary-treasurer, and a member-at-large who have been added. Previously, it was president-elect only, and now we're going to have a president-elect, secretary-treasurer, and a member-at-large. I, as the vice president, go on to be the president starting in January, so I guess we get to see a lot more of each other. Finally, the delineation of privilege project is continuing to go on, and I'm really excited about this because I'm the chair of Credentials Committee. And our privileges, they were in need of some updating. There was some discrepancies. Family medicine had some things that internal medicine didn't have, and there were some conflicts that we weren't very happy about. So we very graciously received funds from administration to hire an outside consultant to help us with this project so that we could bring these privileges up to speed, so to speak. And that privilege is really going forward. I think we've got 6 to 10 new privileges in front of the chairs who are currently undergoing review, so you should all expect to see a lot of privilege forms coming forward in the next few months. To that end, I do have for your consideration a laser privilege form. This is a new form. It's a consolidation of privileges across departments. Any department using a laser of any kind would use this privilege form going forward, as opposed to each department having their own laser privilege form. It was combined into a single one. So I put that forward for your consideration and approval.
What do you think, Mr. Chair?
I picked a perfect time to ask for the approval. We've lost the chair, so. Get like okay.
Mr. Boss, if you can assume the chair duties for just a moment.
Okay, all right. Are there any questions on the laser privileges? All right, there being no questions, I'll entertain a motion for approval. Second. All right, it's been motioned by Steve, second by Zim. All those in favor signify by saying aye. Aye. Those opposed by nay. All right, thank you. Thank you very, very much. So next we will, moving right along, Dr. Becker, you would come forward.
Good afternoon. I don't have anything as rousing as what Laura presented. and just so you know, Dr. Weber, a surgeon, quoting Dr. Osler, who happens to be an internist, is a pretty rare event. So I could probably take an extra jab while he is gone at doing that. I will give you a brief set of comments. And in advance, I will read you a statement at the end, just for your consideration. I'll be providing that actually at the next board meeting for further review. So as I mentioned last time, I'll orchestrate all my comments via a basic structure. We'll start out with clinical. The scorecard is in evolution. I do want to highlight there are quality parameters that the service lines within a claim have tracked. They also include a core set of a claim quality parameters. Performance for the first half of the year, which was just reviewed so that there could be reconciliation and then ultimately an incentive payout, actually exceeded goals that were set for reducing 30-day readmission, decreasing what I would term ambulatory sensitive emergency department visits, chronic conditions that are out of control, for which somebody then goes to the emergency department, and decreasing amputation of legs and toes for individuals who are at risk. As Laura showed, we actually did well outpatient and behavioral health in terms of patient experience scores. We missed about 28% of the time in some of the other parameters. So we have some work to do, and we can also improve performance in these areas. From a strategic standpoint, we are continuing kind of an inventory assessment of what we can do to facilitate and support how we're going to care for our connections patients and our other patients in our value-based care contracts. At the same time, we're needing to see patients. I've now hit 13 of our sites throughout the county. We have maintained our clinic volume, and I don't want to steal any of Ms. Clark's thunder, but you will see that primary care is at least above budgeted target visits through the end of July. Specialty visits are down slightly. There is an encumbrance at the moment, just as we're dealing with, on the inpatient side, COVID as a clinical condition. The increased volume of ordering COVID tests and the orchestration of that at sites where we are not offering it has actually taken a fair amount of time over the last 2 weeks as that's become more critical for patients and their families. And it is, I would say, an extra layer of work on top of what people are normally doing in the clinics. In addition, I've been working with Mr. Hallman as well as Lauren Poe in the Office of Strategic Management, just trying to get a gauge of where our physician practice, our provider practice actually has a better opportunity to help advance what we're trying to do strategically on behalf of the network, and some of the opportunities for assessing and using innovation, whether as a pilot for us or as an opportunity to test something that we could potentially expand. There's some significant opportunities, I think, there that align with what some of the service lines have put forward last year in a very preliminary fashion. Organizationally, I will come back to it at the end, but I will give you a quick update on Guidehouse and the compensation plan work. I want to do that after touching on the last couple items. Financially, you will see that we have a $10.5 million positive variance from budget through the end of July. Some of that is attributed to an increase in clinical revenue, about $4.5 million. A large chunk of additional what was unbudgeted revenue as well that has hit the books for the network and a claim is the fact that we've increased our value-based care revenue. Unaudited and very preliminarily, it's above $3.5 million for this fiscal year, and that represents a significant increase from only $750,000 last year. In addition, I think we've been pretty good with managing some of our expenses over the last couple months. Our OpEx is down about $6 million from where we had anticipated. Some of that is related to not having some of our hires come on board at the moment. Also preliminarily, revenue cycle performance in August was good. We're up about $1 million compared to what we anticipated from budget. That does include a very nice payment transfer from JPS, but the collection rate, absent that, is still the highest it has been for this entire fiscal year. Some of the rigor and work that the revenue cycle team has been doing in concert, that's Mike Ray and his team working with Rory and his team to really get things better in line. We are finalizing an emergency medicine RFQ. We will be coming back to you in the near future with a recommendation related to that. I will also be letting you know I'd like to add Dr. Alawi to the acclaimed leadership team to take on some very focused work, helping us with clinical performance and new care model generation and work with community health and population health. And I will, as my last item, let you know our work with Guidehouse for a claim is kicking off. Organizational structure, RACI, a very large RACI matrix, as well as some organizational assessment. And then in terms of compensation, we are on time and on target. We have had 6 meetings of the steering committee that includes senior physician leaders throughout a claim, as well as some of our JPS leaders. They have generated a draft compensation philosophy, which I did not include in your packet, but I will read in a minute. They are going to have a 7th meeting here later this week, and then we have created 4 work groups, one of which will focus on primary care, one of which will focus on specialty care and behavioral health, one of which will focus on procedural care. They are, at the moment, to be populated by physicians from most of those domains and also cross-fertilized by 1 or 2 other physicians from outside of those domains. And the administrators from several of the acclaimed service lines will serve as the administrative support for those work groups. They have a 2-month timeline to complete their work and bring some thoughts and recommendations back to the steering committee, which then would report back to leadership and then provide you with an update, or I would. So that's on target. The timeline for that actually is to begin overall communications with the physicians through a fairly extensive communication plan that I've drafted beginning in November. We would start shadow modeling their compensation via the new plan beginning January 1, 2022. And we would have a vote of the physicians within acclaim for that new plan later in the spring of 2022 with the target that it would go live beginning of Q3 2022 calendar year.
When, Brian? When would it go live?
The start of quarter 3 2022. So July 1 is my target date. Gotcha. I know that feels at times lengthy. This requires a lot of physician buy-in, and I also think it's important for a number of reasons to have a lot of dialogue about this. The compensation philosophy statement, which was drafted, and I am bringing this back, I think, as I said, based on the chevrons on the initial presentation that we had, reads as such. I'm just asking you to hear this. I'm happy with Mr. Early's permission to then discuss this offline with any of you, and we'll bring back this in a formal document at the next board meeting. Pending one caveat, I'm taking my board examination that day, so I have to finish and get back. The acclaimed compensation plan will be dynamic, understandable, equitable, competitive, and designed to incentivize performance outcomes aligned with our network's strategic direction. That was crafted by the steering committee. Any questions?
Yes, a couple,
Yep.
Brian, and part of it is just education. Differentiate for me, you mentioned the value-based care revenue stream improvement. Tell me where that money comes from and how it's differentiated from our other revenue streams.
Fantastic. So if you come in and see me and you're just a straight visit, I'm going to do my stuff and I'm going to document and I'm going to drop a charge in straight fee for service.
Okay.
We have a subset of contracts, and I'm actually working on how we can improve those. We have a subset of contracts which pay either global payment in a very small subset. In other words, we get money in and we have to take care of the patient within that dollar figure, otherwise we lose. And or they include other types of incentive or quality payments. Those are the contracts which, for certain reasons, require that we have annual wellness visits for patients, or that we get certain quality metrics, such as making certain, you get a certain blood test when you see me, or I document your blood pressure a particular way. That work, which I know sounds like it ought to be the same stuff, often isn't. Could be my fault, but it actually is also extra stuff that often gets done outside of that encounter when you go see the physician. That is put into a different bucket by the payer. So we have, I mentioned last time, we have Medicare Advantage contracts with WellMed, with Cigna, with United, and so they put a chunk of potential money over there for achieving those measures. That has nothing to do with what we're doing with taking care of the patient, just get those other things done and actually get them into a range. That's how that revenue is a revenue stream for us,
So it
different
doesn't
from
take money
fee-for-service.
from one bucket and put in the other one then?
They actually separate it. They don't really take it out. It's not, they're not going to reduce your fee for service on that one.
Okay.
That's just a separate bucket for you to earn. Consider it pay for performance.
Okay, so it's like incentive pay, basically?
Yes. Yep.
Okay, good, thank you. I'd never really heard that explanation, and I appreciate you indulging me on that. Another question, as it relates to the current RFQ being prepared for ED, can you give us kind of your philosophy and where you believe that needs to go in terms of, not in terms of specific providers, but in terms of scope, in terms of partnerships, in terms of joint ventures, in terms of where a claim can begin to take advantage of some of our provider partners in ways that ultimately not only help them do what they do, but help us expand what we do. No. So, yeah, I'd like to hear, because this is the first time we've had an RFQ for ED services in some time. A claim, obviously, our current ED contract has not been associated with the acclaim element. If we are to move forward, as I'm sure you will, in trying to improve both entities whenever we introduce a new group to a claim, I'd just like to hear your philosophy on what that benefit should look like and how an RFQ helps us achieve that benefit.
So
that's about as summarily as I can get.
The strategic value of having a quality partner aligned with what we are trying to accomplish in the emergency department, number one, is fairly obvious if you're coming into this building. It is a front door to much of what happens under the confines of this roof. That strategic partner has to be able to align with and achieve probably not just what they feel is their good performance, but in fact, some of the things for which Laura just presented. We want to make certain that that experience that a patient has in that environment is exceptional. We want to make certain that the quality of care and some of the achievement we do have in terms of how fast patients are seen, how fast patients move when they have a critical condition, and how they are supporting the fact that we're an exceptional level 1 trauma center are all important. That is not the only strategic value of such a partner for emergency medicine. If we think about what's happening in the community, both what you see, I mean, I drive around here, you have been here much longer than I, but the proliferation of urgent care facilities and standalone ERs is fairly extensive. And that is, I'm also going to suggest a slightly backward-looking model of healthcare. Having a logical emergency medicine partner allows us to think about the ability to consider access for care for our patients outside of this environment, but aligned with JPS and with what a claim can do. And that gives us a different potential physician footprint to access, a potential partner for a new absolute footprint in the community when we talk about bricks and mortar and types of facilities, and an opportunity to refine how we use our specialists and other services within a claim more effectively without having actually to go hog wild on other primary care physicians. So at first pass, I see it as absolutely primary that they are, whomever they are, an exceptional partner delivering service downstairs, but I also see them as a potential very important partner for what we would like to do throughout Tarrant County.
So your process then will include that capacity as one of the rating criteria for the service?
It is embedded in a subset of the questions. It's not formally called out. I did not help draft the original piece for that, and that's why I'm a little hamstrung, but it will be part of the discussion.
Well, I think that's a great answer, and I appreciate that answer because we have worked very long and very hard, many of us in this room that have been around here a long time, on what we do downstairs and how we improve downstairs. Door to balloon time, left without being seen, all those metrics. And many of us have been a part of that since the very first day. But I think there's also tremendous opportunity that gives JPS the opportunity to expand our footprint in ways that today we're losing money. We're not able to take advantage of some of the services that you mentioned. This proliferation is one of them. We could be in the middle of that. We could be helping a claims revenue stream. We could be helping our own physician partners. We could be becoming more efficient in how emergency services are dealt with here online throughout the process. So I appreciate that answer. I mean, I applaud it. And I hope as that process goes forward that we really look at expanding the scope of that potential more than we have in the past.
Okay? Thanks.
I want you all to know how much you all should appreciate Brian Becker. The 6 meetings that he has had on the comp committee have all started at 6:30 a.m., and none of you all have asked to be on those, and he has not asked you all to be on those. So just to let you know how much you should appreciate this guy.
It is because of the OR schedule, I just want to point out, Dr. Weber. Okay. Thank you.
Thank you. Next thing I have on the list is committee reports, and the first is joint finance. Steve and Trent.
Thank you, Mr. Chairman. I'll give the first half of this. The Finance Committee and the Planning Committee met jointly on August 26th. The Finance Committee portion of it, we considered we have several recommendations for you. One was the July financials that Ms. Clark presented, but a couple items I wanted to highlight was we are submitting for y'all's consideration the annual contribution for the pension program and for the GIBA program. And we also are putting forth a contract with the District Attorney's Office for their collection services for us that Mr. Walker helped negotiate for us. So thank you very much, Daphne. And then several other contracts that we're recommending for y'all's approval. And that's my report.
So on planning, as everyone knows, we've joined these 2 committees just to make it a bit more efficient. And as you all know, we have released staff now to begin releasing RFQs and RFPs on the street. As those are released, they will be put on the portal, so everyone has an opportunity to see those. We have our next steering committee meeting tomorrow. We've already worked on the agenda for that meeting. We've made certain that we have invitations out not only to the county administrator's staff, but also to the county commissioners themselves and their staff if they're interested in attending those meetings. Anxious to make sure that that process is as transparent as we can make it, and that as we move through now to some sort of exciting new milestones, that we keep those communication lines open at the lowest possible level so there's no surprises down the road. So we look forward to that meeting tomorrow and starting to look now next at our medical homes, where they go, what they look like, what that footprint is, how it is designed. That's going to be the next sort of exciting, sexy things that we do, because a lot of stuff involves parking lots right now, and that's really not too sexy. So we got some cool things coming.
I don't know how to accomplish this. If it's possible, I don't know. Can a news release be prepared of what our plans are that can go out prior to us making final decisions, just informing the public of here's our process, our steps?
Just from the standpoint of making sure that the community knows where we are in the process. For example, if, Ralph, I'm asking you.
Yeah.
If we are about to release a set of RFPs and RFQs, make sure that that announcement is clear and that everybody has an opportunity to recognize these are coming. Is that the kind of communication you're talking about?
Plus some explanation of why are we doing parking lots and not buildings? Okay.
I think that's a great question. And part of that has been really us kind of relying on Broadus and our staff to tell us what the sort of the first step moves have to be before we can do some of the other things. And for example, the parking lots, we can't very well go tear down buildings and build new ones if we've got no place to put the people that are going to be displaced. So a lot of that, I think, has been implicit in what Broadus has been presenting. But I think, Robert and Daphne, tell me if I'm wrong, but I think our plan is to make sure that once those schedules are completed, that we not only put those on the portal, but that becomes part of our overall communication process with the bond campaign, and that it is made more broadly available to the community so they understand what's coming and when to expect it. Is that accurate?
Yeah. We currently have a website dedicated just to bond. It was part of the pre-bond. Now it's part of the information about that. So we'll use every social media and every outlet we've got to update people as to what's happening in planning. We have to be careful that we don't get out in front of somebody. I don't want, to put something out there and the commissioner said, well, we didn't discuss this. Because I do find some of the issues that we deal with the bond are a little bit walking on eggshells, but that's okay. I think if we inform everybody and let them know what we're doing and we're very transparent and very open about it, that's very helpful. So your point is well taken, and we will do that through multiple avenues of information.
Yeah, I just want to make sure that we get our message out before the Star Telegram gets its message out. I'm getting flack.
Okay. Yes, sir.
Yeah, I agree with Ralph. The community as a whole does not know what we're doing. They just know we haven't been doing it. Mm-hmm. And so I think it would be important that we, and it doesn't, I don't think it needs to be, this RFP was let out and approved and whatnot, but just the general status without getting into the details, because you're right, once you get into the details, there's a hand grenade in there somewhere. Mm-hmm. But just every so often a status of where we are, mm-hmm. and the generality of what we're doing, and as Ralph pointed out, why we're doing a parking lot before we're doing a building. Sure. I think would be very helpful.
Yes, sir.
And Reverend Emerson and Trent, we talked about and even in the first steering committee meeting, at some point bringing in a member of the communications staff to sit in there and hear the real-time information to keep us up. I don't know if we're to that point yet, but we did talk about that in the very first meeting.
Multitude of JPS efforts that have been on websites, they've been on 100 different places, but unfortunately that doesn't get the same readership as a Star Telegram article. So it's always going to be a challenge, but I think, Roger, you're right. I think we need to include, at this point, probably someone from the communication team at all of those steering committee meetings, and whatever we're not doing, we need to start doing when it comes to trying to get that word out. But it's tough.
And I also think part of the plus is going to be, to Zim's point, and even Reverend to yours, people will hopefully get accustomed to looking at those outlets that we do put information out, not just one source, because we do have that site that people can automatically go to and get updates. I think the steering committee is hugely helpful, and after those, we can sort of give an update as to what's going on.
Robert, I think that's a great idea. I think most people don't know about that website.
Sure.
Ralph and I have talked before. We're not picking on Star Telegram here, but their electronic version, if they see a headline, it hits their electronic.
Right.
And half the people all they see is just, they don't read, and so they don't know about that website. So I agree.
Right.
We're all saying the same thing. Communication is a key to cut off those questions. We get those calls, well, I thought y'all raised this money too. We are doing something. We've got committees engaged. So again, Trent, I think what y'all are doing is great. Communicate more, and I think we're right.
Reverend, can I ask a quick question? Are you talking about the community as a whole knowing what's going on, or the individual contractors and people working on the projects, or both?
Actually, I don't get as many calls from contractors as I do community.
Okay, I just want to make sure that.
I should say negative sensationalism. Yeah.
Media has.
Right.
Star Trek?
Make it so.
We'll try that.
Or so let it be written, so let it be done. You know, that, we have to approve your reports, do we not?
No.
Okay. Thank you, Steve and Trent. The next one I have is the Governance Committee and/or Action. Roger.
Thank you, Mr. Chair. After we got the riffraff out of the way from planning and finance, we had a very abbreviated meeting of Governance Committee. We had a chance to meet Colin Warenka, which most of you have not yet met in person. He had a family issue today, so he couldn't be here today. He called me this morning to let me know, so he apologizes. So he will get you at the next one. We have no items to move forward, and we look forward to the next meeting. Colin did say they will be getting new action plans together once he has a chance to get his signature on things here. So,
Good work.
Can you summarize that report?
Just for the record, I'm Riff and Tom is Raff.
Okay, next one I have is Quality Committee and/or Action from Zim.
Thank you, Mr. Chair. The committee meeting didn't get started right away. There was a small boycott. The chair assumed it was because of the change in leadership. And so after about 15 or 20 minutes, we finally did get a quorum and were able to conduct our business. We reviewed a number of actions, and some of those require board approval, and they're on your consent agenda.
I would like it duly noted that I was sitting here waiting with Zim very patiently.
Amanda, sometimes when you speak and you're not guilty, it makes you look guilty.
Oh, man. Okay, item 11, update board discussions, consider approval of the insurance policy renewal for Daphne.
Thank you, Mr. Chairman. I don't think we have a PowerPoint, but there is a handout. We were working diligently up to the last minute to try to get you some updated information. As a reminder for those who were in attendance, we recently presented a request. Well, look at there. Every time I think I don't have a... So we do have the presentation. You know, we recently presented this request to move forward with our insurance renewals at the August Finance and Planning Committee meeting, and we were asked to explore some other options and bring the request back to the full board. We did begin to undertake that work, and I'll share the information that we have to date. Please keep in mind that all of these policies expire at the end of this month, so this is really our last opportunity to present at a scheduled board meeting for approval. There are a few concepts that were called out specifically during the meeting, and I'll address those first. The first was the idea of potentially exploring reinsurance. As you probably know, reinsurance describes the practice of insurance companies purchasing insurance to cover their insurance. Through that practice, they are passing on some of their insurance liability to the other insurance company. So this is not sold directly to insureds, so we're not currently able to take advantage of this option, but could explore this if we were able to establish a captive at some point, and I'll give a little more insight to a captive approach. Self-insurance, JPS could insure its own claims up to a certain amount and likely purchase excess insurance to cover events beyond those amounts. As you know, we're self-insured on our medical malpractice currently. However, excess insurers may be concerned over the reporting and handling of claims within the self-insured limits. This option requires posting of a cash escrow and an evergreen letter of credit to support the payment of claims within the self-insured limit. Additionally, excess insurers may be precluded from writing coverage over a self-insured program by their own excess insurer. Captive insurance, that's another avenue that we could explore. If we wanted to have a captive, JPS would need to create a licensed insurance company to provide coverage for itself. Some benefits are that we would have direct access to reinsurance markets and potentially maintain cash that is currently going to insurance premiums. This option would require a pretty in-depth analysis and at minimum requires an actuarial review to demonstrate the appropriate amount in reserves. And our outside consultant would estimate that would probably take us 6 to 9 months to review and establish. We would set parameters for the captive, establish the retentions, and charge the premiums to JPS. There are some tax advantages available to a captive. We can't say for certain whether or not there's going to be prohibitions or restrictions. We'd have to get through that analysis, and that would take us a little bit of time. So with respect to an insurance evaluation of the overall program, the process for exploring options outside of our traditional insurance model will require some additional time beyond the period in which our existing coverages will expire. But in the meantime, we're still pushing to make sure that we're getting the lowest premiums possible. We will also, in that evaluation, we would evaluate benchmarking data, et cetera, contemporaneously with the other evaluations so that we could represent all of the options before our next renewal period. So we just really don't have time to get through that sort of analysis for this year, but we've done some things to hopefully bring down those premiums some and make that more palatable for this year. I think we may be on the next slide. So this slide just covers the renewal coverage recommendations, and we'll get through to talking about our approval requests. As I mentioned, we're continuing to work with our broker to get proposed premiums reduced. We have, if you can go ahead and go to the next slide. This chart actually does reflect some of those efforts, but we're still waiting on some revised quotes. This looks a lot like the first one that we presented to you at the Finance and Planning Committee with the current, some of these are best and final premiums that we're able to get. The ones that are in blue are ones that we're still negotiating. Some of the discussion was really around a couple of areas, the alpha terrorism and the regulatory liability, which I think we were all, and the board members were in agreement that we likely can do without those coverages, and so we're not recommending that we move forward with those, and that will reduce that number that you see at the bottom of our overall maximum premium that we're expecting, another $615,924. So instead of that $2,902,000 number, it would be $2,501,000. But this is right now where we're at. To talk a little bit about the two largest increases, the cyber liability, we can explore increasing our retention amounts. As we looked at that, even if we went from increasing the retention from about $500,000 to $5 million, we didn't see a really significant premium decrease, probably only about another $100,000. So we're increasing our risk without taking a significant premium decrease. We don't really recommend taking less coverage. Right now, we're sitting at about what is average for healthcare entities our size that have the same types of risk. So that the amount of coverage that we're proposing is consistent with what we're seeing across the market. So I'll pause there and take questions. And Mr. Petty, in particular, I want to make sure that I address your thoughts on what we should be exploring and kind of explained what we'll need to do there.
Thank you, and I appreciate that. It's pretty eye-opening when we have even with these reductions, 32.6% increase in premiums over a period. I guess my question, Daphne, and I do think it will be time well spent over the next cycle to look at whether or not some of those alternatives can save us some money.
I think so too.
And I guess I would just procedurally, does our process work by do we contact a group or an entity or consultants that then go out to the market to place all these? Is it one consultant that does that? Is it in-house? Tell me how that process looks.
So there's a couple of things at play. One, we do have a consultant that we work with that gives us, that is really for our benefit, to give us information about what types of coverages or what amounts of coverages we should need, give us market information. We can, Raina and I have talked about that. We can probably leverage them more to involve them more in the analysis to get better information. And then we work with the broker, who of course is paid by the insurance companies. Right. So we want to make sure that our consultant is heavily involved in that process to make sure that we are getting the best rates.
Okay, that's the piece I think where there may be some exposure. Is we're kind of, the broker's incentivized to give us the largest incentive, the largest increase they can.
Right, and we did push on that a lot, and with cyber, I'm pretty confident. I asked tons of questions and we pushed really hard. These increases in the healthcare industry are being seen across the board, and that is probably definitely one that we're going to need to explore, whether we should do a captive model or self-insurance, because they're just going up. And additionally, I think I've mentioned to you all several times that we've had third parties that do handle information on our behalf, shifting that liability back to the provider.
Well, I appreciate you looking into it. It's a hard pill to swallow, but I know we got to swallow it. But thanks for looking into it.
Yeah. First off, never underestimate this hospital system's ability to put together a PowerPoint presentation.
We had it together. I just wasn't sure if it was loaded so that you guys would see it on the screen.
Because what I've learned is we will put a PowerPoint show on for sure. Hey,
you are correct.
Can you give me the definition of the regulatory insurance and what it covers?
Of a grade what?
The regulatory insurance and what it covers?
Yeah. So the regulatory insurance would cover things such as an allegation of fraud and abuse or government liability. There would be a lot of, in my opinion, there would be arguing to see whether or not there was actual fraud committed and before they would actually cover a claim. But the types of things that are covered under that are going to be like your government investigations, any, matters that similar to one that we just recently resolved.
You can see where I'm going.
Yeah,
was this coverage in place?
Sure.
A few weeks ago?
And I will, some of that will be discussion for close.
Okay.
But what I can say about that is that we did get some coverage of that issue, not through the regulatory, and no, we didn't have it at that time.
Okay. And the only other thing I know in my industry, captive insurance policies are a very good way to provide the coverage necessary and also provide a future revenue stream.
Sure.
So,
Sure.
throwing that out there.
Yep.
Daphne, I appreciate what you're doing. In my industry, I just got back dealing with the federal and state regulators, and you look at that cyber liability, and you see that huge jump. And that's the unknown, unless you need it. You say, why are we doing that? But in our industry, in the financial world, the banking world, that's the number one concerns now that's coming up. It's not just somebody broke into our accounts. It's ransomware. It's all of it nowadays. So, I mean, you look at those premiums, they're going to continue to go up. So I admire the fact we're looking, prior to the next renewal, we're going to look at some other, hopefully, options, because I think that's just going to continue.
Are y'all seeing these same kind of percentage
it's going through the roof. And like I say, and again, I'm not one to, like I say, we all face it in all our industries, but I mean, even from the Fed, the comment to us in the banking business is, banks are not, we're set up now, we're dealing with third world countries back in those groups. We've got all the IT and I've got 8-10 people in compliance and all, it's just a never ending, it's constant with us, and it's probably constant with the hospital also. So I admire what you're doing. We're going to look at some other options, but you see those numbers, I think some of those are going to continue to go up. So I like what you're doing, Daphne.
Okay, good. Thank you. Are there any other questions?
Reverend Emerson, thank you for allowing us to talk about insurance without having PTSD.
Oh,
you did a very,
he was
very
twitching
good
a little bit, but
you sat there quietly eating your strawberries and that's very good.
I was admiring his patience as
I
well.
know he was about to come unglued when we mentioned insurance.
This is Emerson Insurance Agency.
Well, if there are no questions, we are seeking approval to move forward with entering into the policies that are listed here, except for the ones in gray, and unless you all have changed your mind, we are not going to move forward with Alpha and regulatory. Mr. Fisher, if you wanted to discuss that anymore in terms of the situation that we had, we can hold the approval request till after close, but if we've answered your questions sufficiently, then that is our request.
I think it would be prudent if we waited till after the discussion.
Okay,
And
that's fine.
take care of it at the end.
Okay, so we'll table that till after closed session. The next one I have is approval for the appointment of Mark Hallman to represent Tarrant County Hospital District for the city of Sansom Park TERS.
Mr. Chairman, what we're doing here is with the retirement of Ms. Labby from the organization, Mr. Hallman, one by one, will be taking over all of those responsibilities. This is just the first one that's come up for renewal. And Mark is here, which means he's not running away from this responsibility, so we're very proud of him. So he doesn't. He doesn't yet. We're not going to inform him of that at this point. So if you all would consider Mark as the one serving on those TERS boards throughout the county, you will see this frequently as they come up for renewal.
Move approval.
Second.
Discussion. Seeing none, all in favor say aye. Aye. Those opposed say no. Motion passes.
Congratulations, Mark.
Lucky you.
There's no hiding now, Mark. Thank you.
The next I have is item 12, which is the consent agenda. If anybody would like to pull any one of these items off, we can do that. If not, I'd entertain a motion that we approve the consent agenda. Discussion. Got it. All in favor, please say aye.
Aye.
Those opposed, say no. Motion passes.
George second or
Reverend Emerson, second.
The legal counsel, you have something else? Or wait for closed session?
We're waiting to close.
Then we're up to reconvening an executive session pursuant to Chapter 551 Texas Government Code. How about if we reconvene at 3 o'clock, 15 minutes, 6 minutes?
All right.
Or we can keep on going.
6 minutes.
Yeah, okay. 6 minutes.
Was that a motion, Dorothy?
Take 6 minutes, take 6 minutes.
All right.
go.
Okay, I'd like to reconvene in open session at 3:40 for deliberation and or action deemed necessary regarding the matters listed.
Thank you, Mr. Chairman. The Medical Executive Committee would like to request the board approve the medical staff credentialing as presented in the closed session.
So moved.
Discussion. Hearing none. All in favor, please say aye. Aye. Those opposed say no. That's the only business that I...
No. One more.
No? Oh, I'm sorry.
No, sorry. I'd like to represent the request to approve us moving forward with our insurance renewals. And I think that we make sure I have the decision correct on whether or not we move forward with alpha terrorism and regulatory.
I'll move approval with the recommendations without alpha and without regulatory.
Okay.
Second.
Discussion. All in favor, please say aye. Aye. Those opposed say no. Now, is it? We're done as far as I know.
I'll be on your schedule.